One of the first mentors that I want to talk about is Warner Slack, who was really the first person who used computers, put patients in front of computers, and was trying to use them as a resource in clinical care. And you can see this quote from Warner when he was there that he would actually use we'll see some of the stuff he was doing before there, but that the idea was that computers could directly interact with patients to their benefit. And we're really starting to see this come true in the setting of e-health and AI, but we're also seeing some adverse effects and things. But we don't really want to mistake the effects of computer dialogue with AI. So in settings where there's a social stigma associated with disease, where there's psychiatric symptoms, sexual practices, drug use, that in study after study, it's been shown that patients are more willing to describe involvement with these problems or symptoms to a computer in a interview, whether it's text-based or auditory, it doesn't really matter, than they are with a person. So that's something that's not AI dependent. It's actually something we've known for a while. So for example, when I wanted to study intimate partner violence, which is epidemic in the United States, that 20% incidence over a lifetime, 1 to 2 incidents per 1 to 2% of women per year. There's little data on the impact of screening and care and other things. And of course, I asked ChatGPT to generate a picture of someone being interviewed to be screened for intimate partner violence. And that you see here that it's a pretty value-laden image, and where a young white woman has obviously been beaten and abused and being interviewed by a black woman. You imagine switching the roles and other things like that. It's you can look for yourself and kind of see that AI is pretty value laden in these circumstances. Anyway, the point here is that what does this actually look like when a provider is screening patients for intimate partner violence? This is what Epic looks like currently. Pictures from our Epic instance at MUSC that screening is done as part of like a long chain of different activities that an MA or a nurse needs to do as part of that. And then they click off things that signs that they may see or ask questions about suspected abuse and neglect. The we came up with a different approach to do this based on Warner's principles. We treated this as a patient population, and that we turned on a different alert in the Epic system once a year to complete this questionnaire until it was completed in all women between 18 and 49 years of age. And then when you turn that on, this turned the Epic instance that the provider was using into a kiosk where they could allow the patient to sit directly in front of this without having access to other Epic functions. And then the providers left the room as well as any other family members, and the patient completed this by themselves and clicking on the exam room. And if they said yes to the first level of questions, then they had a subsequent level of questions that they were asked to try to gauge the risk. And then the providers, if there was any positive responses, got a best practice advisory to go complete an additional assessment. And me go back. So we did a large AHRQ sponsored study screening 9,000 women in 15 clinics in a step wedge trial. and that looking at control rates and intervention rates for this study. And what you can see here is that this intervention increased the rate of screening, even though it wasn't always screening using um, the kiosk mode that we created. But overall, there was much more screening of the patients. When they used the kiosk rate, the detection rate for IPV was about tenfold higher, so that we captured about 160 patients at risk for IPV with this. But half of them were at very high risk for IPV. And now we're working on replicating this finding in another institution. So to kind of sum up here, that there are a lot of computer effects that should not be attributed to AI, and that would be a checklist effect, the order sets effects, bias reduction, workflow optimization, safe practices, and others. Now, AI may make it easier to create custom coded solutions to do this, but these aren't AI effects. These are just standard informatics effects. So let's not miss that. Now, I want to introduce you to another mentor of mine, Chuck Friedman, who helped me write my first grant. And that Chuck is the author of a lot of work on the learning health system and a leader in this area. But before he did that, and before his time at the Office of the National Coordinator, he wrote the fundamental theorem of informatics, which you can see here from his 2009 paper. That the idea was that a human plus the computer exceeded human performance. And what informatics wasn't was creating computers that exceeded human performance. Now, this is a very interesting lemma, and it's obsolete at this time because we're in a world that when this was written in 2009, we could never imagine where computer performance in different areas using AI exceeds humans. So, for example, this is a paper from Nature Medicine showing that when you're looking at a whole series of routine tasks that physicians perform, that ChatGPT alone performed better than physicians, and that physicians plus ChatGPT did not perform better than ChatGPT alone. So you look at this and kind of say, well, that's not, this fundamental theorem of informatics. What do we do in this kind of world? Well, it actually turns out that AI best physician performance across a wide range of studies, and that you can see this on this tornado plot here that in most settings where studies have been published, and these are mostly studies of in radiology, but they're in a wide variety of fields, that AI bests human performance overall. You'd say, Les, how do you keep track of all these papers? And the answer is that you can't. You need to use a large language model to process that. So this is kind of a pointer to my a paper that I've written on use of LLMs to track LLM use in medicine with Dmitry Shirvikov and others. And this is another paper that was just published that is really interesting, using the same methods, but sort of with other things described. That I think the most interesting finding here is that 3.2 papers a day are published comparing humans to LLMs in medicine, and that performance overall in this setting was a little bit more optimistic than the one I saw there, though the quality of the studies was a lot wider and broader, but that it's really questionable whether physicians perform better. And the issue here is that it's not just that whether computers perform better than humans. It's whether what what happens when humans use AI assistants. And this is a nice study that kind of illustrates what's going on. That it turns out that when humans plus computers together actually only work better at the highest levels of human performance. This is kind of a difficult concept, but when a human is combined with a computer, that there's two things that happen. There's a bias toward an automation bias that's seen where people accept the computer's recommendations. But the places where they override it in this particular study, if you were not a very high performer, you overrode it in the wrong areas. Whereas if you were a high performing physician, you tended to actually you tended to do better. So this idea that there is a of improving human performance that's embedded in the fundamental theorem of informatics is a difficult one to achieve, and it's something that we're going to have to think a lot about how we do this. Um, so what's changed? Large language models have become good at simulating human thinking in agentic applications. Uh, the languages of biology have been mastered by LLMs. Self-programming has been applied to agentics to scientific applications, and I'll show you some examples of this. So, for example, uh, we can have co-scientists from AI agents, and that these will uh, act as different team members, configuring things, working with a single scientist to discuss what's going on. This kind of agentic approach says that you're not really dealing with an AI plus one person. It's really a community of AIs trying to augment the scientist, and that gets to have some interesting effects. Second, AI has got languages outside of English that it speaks. It speaks languages of biology, as we can see from AlphaFold and other efforts to develop large language models that are more visually oriented, that don't use medical language or printed materials for structuring their inference from observations. And last, self-coding AI makes incremental science more trivial. This is some work from Evan Johnson, who's one of the associate directors of our center, who had developed a really important method for RNA batch sequence file analysis. His method, Combat, had the highest level of performance. But this caught the attention of folks at Google who applied their self-coding tools to capture all the published computational approaches to this, and then set about an AI combining different methods and writing new code to best the performance of this. And what's interesting is this might have been the subject of, maybe 10 theses going forward, where people came up with individual tweaks on the combat-seq approach in this. But here, these were all automated, completed in a day or so of programming and of runtime, and then compared to that, so that this kind of incremental science becomes trivial. And sooner or later, after many tries, there was an approach that actually bested what my colleague had produced. So interesting, changes science quite a bit. But not only that, that there's a huge number of AI-generated papers coming into public databases that take a large public database, take a single finding from that, let's say from N. Haynes, and then attempt to publish that association. And then you can see the number of articles falling into this view is rising exponentially, especially as we have different sources like N3C and or other approaches for using large real-world data sources that AI can now do what it was doing with Dr. Johnson's study to human findings and produce papers directly from it or with minimal human input from that. What are the problems with this sort of AI approach to sounding? That humans, when they're engaged in this, There are a number of things that can happen that they might believe that they understand, but their actual understanding is less. There's less depth. There's less breadth to what we think we know. The hypotheses that AI puts out will only be a subset of the possible hypotheses. And then there's a sense, a belief that AI is objective, but AI has a standpoint, as you can see, and that there's an assumption that AI is representing all standpoints when it's really representing just the standpoint that it has in that. And if you need to go back to that picture that we had that AI generated of the woman interviewing, the nurse interviewing the woman subjected to intimate partner violence, you can see that AI has a standpoint. So, what has not changed in this setting and what we're doing? It's really Acuff's pyramid, which is many of you have heard about. I think in our field, this idea that we capture data, we transform data, the raw numbers that are coming out of experiments into information, and we transform information into knowledge. And that those were the three things I was taught at Stanford, and that at the top of the period that Acuff, the pyramid that Acuff, who was not a medical informaticist, but a information technology guy and a business guy, said it was really a wisdom that was at the top of the pyramid, and that the how we use knowledge is really important, and it captures the values that are inherent in humans. Went the wrong direction here. So humans really need to ensure the integrity of science by working to ensure that there's adequate provenance at each step of this, that as we transform data to information, we've recorded the provenance of this and who's been involved in what and what the circumstances are. Information to knowledge, and then has the same sorts of activities and knowledge to wisdom. And that blockchain, eLab notebooks, sharing of ideas and other things like that on forums and authorship version tracking are all critical to this process. And this is a paper that I've described as how the National Library of Medicine might be involved in providing the provenance for the generation of knowledge. Let me illustrate for you, if this stays here, the why the wise application of knowledge is important. Going back here, this is kind of tough when you use builds. So looking at this data set on medical expenditures and trying to predict which people to reach out to that'll have high expenditures in a year. What are the features that are in this model that are consistent with good governance? And I wish I could get a little bit of feedback from the audience here, but you can see that the model is calibrated across a large, wide range of, does it have good discriminatory power? That is to say, people who have low scores are different than the people who have high scores. Are there any differences in the accuracy of the model across minorities? And you can see that this data set and this model in particular has all the features we'd really like to see in a predictive analytic model. But it's also the data set that is underneath one of the most famous papers in racial bias, and that by Zach Overmeyer and colleagues, where it shows that because you chose to predict value, because your values were focused on predicting expenditures, and because minorities have less access to health, that there's a systemic discrimination by using this model to predict expenditures and allocating interventions based on the predicted expenditures. So does that make sense that that if people have less access to healthcare, yeah, they'll predict to have less expenditures, but that doesn't mean you shouldn't reach out to them to get them into care, even though because they might be just as sick, they just don't have access to the healthcare that's in there. So that this is a discriminatory model, and that values matter. That if you predict the wrong thing, that it's just not going to work out very well. Similarly, this is an article that I published at the start of my career that started look that was looking at values, and that it's possible to predict who's going to die in the hospital, but maybe that's not the most important thing that we should be predicting. Maybe we want to predict the people who are going to live, just not necessarily die in the hospital, but might just live a short time after discharge or die in the hospital. Maybe 100 days, let's say, was our threshold, and we're in the upper 10th percentile of resource utilization, indicating they got a full court press and they had a long, slow, painful death. If they were discharged, they got a few days in response for that. Uh, so it turns out that it's easier to predict this than this outcome, which we call potentially ineffective care, than it is to predict mortality in the hospital, and that's interesting. But it shows you that values are important in these predictions. So we're going to talk a little bit now about what we're doing at the Rutgers Center for Biomedical Informatics and Health Artificial Intelligence. We're working on this idea of combining living laboratories and digital twins to enable an AI-enabled learning health system and research system and medical education system. And here you see the human figure for what a learning health system is about, where you see it's cyclical, and you see a lot of symbolism in this that's succinct and interesting. So, what's a living laboratory? Uh, Coming from another one of my mentors, Larry Smarr at the University of California, San Diego, he said that great leaders don't fit the conventional mold, and that his job was to set the stage, not to perform on it. What he really meant, he was the producer of the show, and maybe the backstage manager, and maybe the builder of the set, and maybe all those other types of things that go with it. Larry was the first person who talked the NSF into investing in supercomputers, and that really created that whole program that is there. But when he set the stage on something, he really set the stage. And that was my inspiration working with him on some work that I did on a living laboratory for coordinated care for disaster sites. So suppose the Iranians got really mad at us for all the bombs we dropped, and dropped one on us, and created a high casualty count disaster. What we don't currently have is a way of coordinating the care at disaster sites to minimize the loss of human life. We kind of have a scoop and go strategy that could easily fail. So a while ago, the NLM had a program where we participated in, where we created a comprehensive platform for disaster sites, where we had a command center, we had tablets for team leads, we had handhelds that with barcode scanners that individual team members could use. We had an electronic triage tag, which stored all the medical records for the patient and would flash when it was time to put them in an ambulance, and also showed what their triage status was. If it's flashing blue, it's not a good thing. And then we also created a pulse oximeter that was on a Wi-Fi network, and that this is before Wi-Fi was widely available. We also built a battery-powered mesh Wi-Fi network with geolocation built into it. So we put all these things together, and then I believe I'm one of the few informaticians who have used a helicopter in an experiment. This is the fire department helicopter bringing the SWAT team to take back the Cal IT2 building, where we did all this work at San Diego. And we had students in white t-shirts and blue t-shirts with a conventional versus paper tag versus our electronic triage tag in the whole system that was there, and tested this in a large-scale trial. And that was the most dramatic example of the living laboratory I've had. Another living laboratory that we've worked on is Helix. With Helix, the sequencing company, we did a 100,000 person genomic medicine initiative, where we were trying to recruit people into this initiative and collect a sample from them and then return the results to people automatically. So it was digital enrollment and consent and order placing in the ER automatically. And this is kind of our living laboratory here around Epic, where we had a registry in Epic, a MyChart interface, consent website, consent database, interactions with to get the orders into Epic to allow patients to access the genetic results from the Helix portal, but be validated through MyChart and so a bunch of different things that are there. So creating this dense network of systems that work together to evaluate that. Kind of what it looked like. You could go into this anyway, but you would sign into MyChart. You would write to our consent form. You could also get the text message and sign in here, and that this would then allow, when you sign the consent, you were automatically enrolled in the study and your tests were ordered and that things were able to move on. But the point is that this was also a platform for being able to uh, take on different scientific questions. So we randomize people using this platform to pictographic comprehension versus a standard consent form, and then measured different levels of comprehension and other activities as part of the consent process. So you could actually build studies into this, making this a living laboratory. And that, so we did that and found that it didn't really change comprehension much, but lots of other studies were possible. So now I'm going to talk a little bit about what we're doing at Rutgers. Our center was established with a $3.75 million award from the president of the university, plus investments from the health chancellor. That these are our four leads. Antonina Mitrofanova is our deputy director. Evan Johnson, associate director for basic science and entrepreneurship, and David Ferran for translational science. We're focused on cutting edge training, research and innovation, social technical infrastructure, and attracting top tier talent so that we've been able to establish a PhD program. We now have 8 acceptances in it. We've got an MD with distinction program in AI that we're building out. It'll cover both our campuses, both the New Jersey and the Robert Wood Johnson Medical School. We have internships, 335 applicants for our 30 or so internships. Postdoctoral fellowships shared between labs to create new collaborations. Pilot grant program, and we've also got a boot camp program where the first year we did AI RNA-seq technologies and AI. 34 students engaged in that, and then this year we'll have a AI guided literature review and a second one on RNA-seq analysis, repeating that. And that we've also had symposia. So we had a couple of symposiums. We have 2 annual symposiums, a joint roadmap symposium, a monthly seminar series, and a Future Med student pitch competition, which is really fun, where students actually are leading work on creation of companies, and we served as the judges in that and mentors to the student leaders. So going on, what are the specifics of this AI digital twin laboratory? One of these things we're doing is building new features into Epic to allow people to do this using our gateway that we created for our genomic medicine project. So we're adding in features to do A/B randomized trials automatically, linked to REDCap for the randomization tables. So to create that ability to do randomization and turn the hospital into a living laboratory for decision support. We're working also on the de-skilling, never skilling problem with AI, and that So maybe some of you have read this article that there's a, and this is actually a fairly broad a set of concerns of people about AI changing the way that we learn and whether we learn the same things and whether we're as good at hypothetical deductive reasoning when we always have someone to ask that might be smarter than we are. Um, the way out of this may be digital twins, and this may be AI controlled, that the um, clinicians um, are on a trajectory. We're trying to create competence in clinicians at various levels, but we have a one size fits all training system and a lot of randomness and experiences. So there's a lot of gaps in what students have. So what if we created AIs that modeled each student and their experiences as they go forward, so that we could match those experiences to the available settings for training and the gaps that the students have. So one of the places where we're trying to do this in a practical way is in surgical robotics. This is a very difficult area to train people with because only you can't use the conventional surgical techniques where because there's only room for one set of hands on the controls, and that it's very difficult to share control in a surgical setting. It is possible to do very good supervision in this, but getting to the basic levels is hard and participating in the same ways. So here we're working with to create an area where we could both monitor the output of advanced surgical robots to detect safety signals. So creating the surgeon's digital twin, helping their trajectory, as well as creating a digital twin of the patient so that we could repeat the surgery potentially in a virtual environment, allowing people to test their technical skills. And we're not claiming that we'd have all this completed, but we think that this is the environment where people could do research to enhance this. Our health system's buying about 20 Da Vinci 5 surgical robots, and we are working with Intuitive on this. Another area of living laboratories are working on is in mobile health. Rutgers has an excellent app for students called the My Rutgers app, but it currently doesn't have any health features. So we're trying to work across Rutgers, more than 70,000 students, 5 campuses, to be able to to add those features, which like with smart and connected health, online programs, AI monitoring and intervention, linking to academic performance, so that we could create a single platform for doing this in our student population with the goal of improving student well-being, increasing retention, and advancing the science all within one application. And so we're just again at the beginning phases of this right now, and that we'll keep you posted as to how it's going. So we what we'd like to do is to move from this future where George is Jetson, the guy in the white, is relegated to vacuuming and other menial tasks while the robots lead, to something that looks more like the flying car or little spaceship that he has. This obviously has a lot of AI into it because George isn't the smartest guy in the world, yet he's still flying through three-dimensional space, relatively safe, but clearly in charge of the AI in his little spaceship there. And that we'd like to create a world like this where there might be very sophisticated artifacts underneath this that have a lot of artificial intelligence in them, but that it's still very much under human control and human-centric. I have to thank the team and our leadership. It's a broad number of people here. You can see that it's far too many to thank individually, but we're really excited by this. And we're hoping to keep moving forward. We've been in business about 5 months now, making some significant progress, but looking forward to collaborations and to advancing this agenda. And I think I even saved a few minutes for questions here.
You did. Thank you so much, Dr. Leonard. And this was a jam-packed presentation with lots of material for questions and otherwise. I'll start with some of the questions we got from the audience. I hope that I have time to ask my own, but we'll prioritize the others. So, the first question I saw come across was a bit of a loaded question, but which comes first, AI or learning health system? So, does the AI feed into the learning health system, or a learning health system feeds AI? Obviously, sounds like a little bit of both, but would you like to comment on how you see that dynamic moving forward as we incorporate AI into our learning health system more?
Yeah, for human control, the learning health system has to come first. Yeah, that we want to create systems where AI contributes to human values and human-led uh, um, performance. And that
So
if AI comes first, we'll just be adopting innovations and putting them in there, but we may not control them or understand them.
that's that I like and appreciate the clear, pointed answer, and that is very much on the priority of it's not just AI in medicine, it is, as you are saying, human-led AI systems. This is important.
Yeah, and that it's a system first, and then the AI fits into that. Otherwise, we're getting close to magical incantations, and that uh, we don't need that.
Yeah, it sounds fun, but n there's no place for that in medicine
Or in science.
or in science. Indeed. Okay. Thank you. And then Blake also had a question that I'd like to just give him the opportunity to ask himself.
Yeah, so first of all, amazing talk. I really love to see your viewpoint here coming from a lot of experience. But I wanted to go back to the autocode section where you talked about Google coming along and outperforming Combat in RSNA or
Yeah,
RNA-seq, right? Well, one of the great things about Combat and one of the pieces that made it such a great novel contribution was that it's a really simple application of Bayesian statistics, right?
yeah.
It's beautiful in its simplicity. So when we talk about autocode solutions and AI-driven models and things like this, how do we combat, no pun intended, the rising amount of progression in results without necessarily progression in incremental steps of the methods, right? So the methods sometimes become more and more opaque as we improve the results, maybe incrementally, maybe a lot. But how do we combat that in a learning health system where transparency and interpretability are really important?
Well, again, I think your question is really important. The reason I chose that example was that one, it was kind of fun. We had Google present this to us at one of our conferences, but it was really interesting to see that they could combine different methods automatically. And that what's the usual way that students, PhD students innovate? They read a lot of papers, they combine a few things, and then they try to improve on this. And I just thought, wow, how many PhDs did they short circuit by this that would have, been tested and done incremental improvement, and that we might have thought of that as advancing science. I think that this shows that we have to define science in exactly the way you described, that unless we're doing novel innovations, um, we're not really doing science. That if we're just doing combinatorics on what we know already, not going to get there. And that AI can do that better. So let's step back from that and rethink how we're doing. So let's think of a new theory of Bayesian statistics that we're applying, or let's okay, we can't do Bayesian, let's do quantum. Let's do quantum mechanics. Let's do something else that hasn't been done before.
Arguing for new baselines instead of moving up from existing baselines.
Yeah, that to say that if we're just combining things, it's and the algorithms are well documented, that can be, it looks like it can be done pretty well by, and you have a good endpoint that you're measuring,
Sure,
that you trust the
absolutely.
values of, then you don't need to do that science anymore. Google can do it for you, or you can do it. You can set up Google to do it once and
There
for
we
all.
go. Yeah.
That
Man in the loop. We always like that in
yeah,
LHS, right? Yeah.
but as I said, that it's a different type of a thing, right?
Different type of thing. Exactly.
That you're not training people by having them replicate things and then kind of extending it a little bit. You're just forcing them to think more broadly.
Great. Thank you, Blake, and thank you for that answer, Dr. Leonard. A couple of specific questions. One about the EHR-based living lab. So, can you please
Okay,
comment on the patient consent process and institutional governance for the EHR-based living lab?
right. So um, uh, the question is really whether we need to do consent of patients individually or whether it would need to be waived by an IRB for this, for decision support. And I think the jury's out on that. I don't have a reading from our IRB. We're mostly working on the technical foundations for this. If we're doing things that have two things that have been approved already that are more, let's say I've tested the intervention by itself, two interventions by themselves, and we know they both work, that's really the context that we're in. So but can I predict what an IRB will require a consent for? On the other hand, I can say that, gee, I have a lot of experience doing just-in-time consent with people, so I'm not too worried if they have to do that. Having done 100,000 of them. So
Yes, I do remember those presentations from the MUSC days that you guys had a whole system for the just-in-time consent, and that was so. Whichever the answer is, there's a path forward, is what I'm hearing.
yeah, so if we have to, but I think that this is an area where waiver of consent is going to be more likely than a requirement for it. But we can deal with that if we have to.
Great, great. Thank you. And then the other specific question I saw was about the digital twins. I know we have some folks interested in implementing that methodology. So the question is, can you describe in more detail what a digital twin to prevent de-skilling would look like specifically? So for medical clinicians, beyond the
Interesting.
surgeons and robotics approach.
Yeah. So de-skilling, this is an interesting area. So the idea would be that you would not give people the answer, but you would require them to figure it out using the digital twin. So, I mean, what I would do would be to, okay, so with the digital twin, what you're doing, it might be, I'd refer you to an older paper I wrote on a different way to write notes called OODA, Observe, Orient, Decide, Act. So I just had a nurse reach out to me about this after about 10 years. It was kind of fun to see that. The thought though is you should always be predicting what the impact of your treatment is and then comparing the observed treatment to that. And so that prediction of what the future state of the patient will be after you're doing things, that's the digital twin, right? And that um, then you can decide whether that's the right trajectory or not. You can get more data as to what the next step is and what the other steps are from AI and other things like that. But you have to be able to decide that you're going to treat people based on what you think the trajectory will be. And that's where the digital twin comes into play.
That makes a lot of sense. Okay. Um, let's see, going through the other questions. This is a good philosophical high-level question about the human-led aspect here. Do you think a threshold should be established for when systems should be or can be AI-led instead of human-led? What criteria should be met to determine when this would be true?
I would say yeah, it's really interesting. So one of the things I just had the honor of participating in was the ARPA-H um, task two order that was looking at supervising AI predictions, that for treatment of patients in for with cardiovascular disease. So I had to think a lot about, how you would do that, and I know a lot of my colleagues were also engaged in that, and so I guess the answer would be that AI should be held to the same standard as humans and be explainable with that. our approach to doing that was a checklist. And that it said, did they think of this? Did they think of that? Did they go through this? Did they do that? That's based on a guideline. And if the AI matches what the checklist is, it passes. If it doesn't, then it maybe needs to ask a few more questions. Other people have looked at this as a risk to benefit ratio or other things like this, but I really thought that the checklist was actually a pretty good way and an explainable way and also something that could teach the AI to change its behavior too if it failed to process the checklist due to some, you know, um, skipping, hallucination, whatever that it was doing. So I think that the combination of those two things, use the AI in the context of review, and then the review has to be systematic and guideline based.
This is very much new territory.
Very much. But we
We're
didn't get
making the
into
rules up
the,
as we go.
unfortunately, ARPA H didn't like our solution to the AI supervision problem. They thought it was it wasn't advanced enough.
Ah. Is there a concern here that we would be too limiting to the AI or the opposite, where we would be giving the
I think
AI
that
too much
they like
agency?
magic more than I do.
I
Sorry,
will
that's
steal
probably
that
going to get me
term
into
for you.
trouble.
Magic, I know. I mean, if you use the word magic, it does kind of, I mean, it
It's
sounds like a
pejorative. I know.
positive. Yeah,
It's not
it sounds
fair.
like,
No one would no one would accuse me of being politically correct all the time. That what I would say is that without the ability to explain AI, or with the ability that we're just using it, trusting its results without, you know, linking it to something we know is solid, that we're moving toward being magicians rather than scientists, and I don't think that that's a place that we want to be. That where we know all the spells, we call the AI to do the work, and that amazingly it happens, but that doesn't doesn't seem to be where humans should be. We should be better than that.
there it is. I think that's very well said. And that's a good closing thought. I will refrain from my questions as to open up, the can of worms again. I think that's a good way to put it. And I know we all appreciate those of you like Dr. Leonard who are writing these rules and coming up with these and applying their experience to think of these things as we move forward into uncharted territory. And certainly we appreciate you coming to talk to us today and give this excellent presentation. So I hope everyone will join me in thanking Dr. Larrant one more time. And thank you all for joining our grand rounds. And we'll see you next month in May for the next one. Thank you, Dr. Leonard. Thank you, everybody.